I'm really honored to have accepted this invitation to speak at the CAPA. And so my goal today really is to emphasize the changes in the WHO that really have an impact on how we deal and manage patients. You'll see in a moment the thickness of the WHO book has markedly and significantly increased. And when I went over the topics, I said, which one of these important changes has an impact on how we manage patients? And that's what I believe you will see illustrated in this hour lecture. So I have two disclosures. The first one is I'm a co-editor of a book on the molecular pathology on nervous system tumor. And I'm also the vice president of a GLI Hope for Salome Association. This is an association based in Europe. The mother of a patient that was affected by a tumor that actually I will discuss today, which is known as the K27M glioma, unfortunately passed away. And the mother created this association that is helping patients, their family to find the best possible care. Some of these kids, some of these are adults, and they are really geared toward the best possible path for their treatment. So here is the issue. When we train our fellow, we try and do every effort to teach them neuropathology, but it's not in a vacuum. We show them how to read imaging, and if you look and talk to our fellow, they will tell you that Dr. Zagzag, every time we do a frozen section, he asks us, have you seen the images? Have you seen where is this lesion? Have you seen what is the suspected diagnosis? And the reason why it's important, because if, for example, you have a very enhancing mass and the biopsy that you receive just show a few cells in the brain, clearly the sample is a problem. And very importantly, you can guide the surgeon, and that's what a lot of the intraoperative consultation we get are geared for. So the imaging is critical. The clinical aspect of the patient, is this a child? Is this an adult? How old is the patient? Is essential. Of course, the morphology, the immunohistochemistry is of marvelous importance. There is no way you can practice neuropathology without paying attention to the morphology because it's a tremendous guide. The immunohistochemistry is essential. You'll see this in a moment. But in my humble opinion, in 2025, practicing neuropathology without genomic analysis, methylation analysis, and all the molecular evaluation is not the way to go. And unfortunately, we have seen issues arising when those tests were not performed. And I'll try to illustrate some of these issues in the next hour. So the molecular studies have helped identify distinct subgroups, have helped tremendously guide treatment, establish prognosis. The data is also predicting the response to treatment, which of course is essential. And the WHO is really a guide, an integrated approach that combines morphology and molecular. And one of the points I want to insist on, if there is one thing you should remember about this lecture, is that no one should do clinical trial without having a full molecular input, because the result will be completely uninterpretable. Basically, you will not know whether or not the treatment you have given to your patient had an effect, or is it because the tumor to begin with was of a different grade with a different prognosis. So the outline of this talk is first, we're going to review the basic grading system of tumors of the central nervous system. We're going to discuss the implication of this grading system on management, on clinical care. And then we're going to mention biomarkers. There are diagnostic biomarkers, there are prognostic biomarkers, and there are predictive biomarkers. So here is an important slide. This is almost 100 years ago soon, 1926. And Dr. Bailey and Dr. Cushing made the first attempt of classifying. And there was a lot of good work there, but clearly they were based on some embryogenesis data, some macroscopic data, but you will see that that is not sufficient. But clearly this was a first significant attempt at developing the current WHO classification. So almost 53 years later, in 1979, people got together and published the first WHO. And if you look at it, it's mostly a morphological description, some codes, and it's of some interest. In 1993, there is a second edition which has some immunohistochemical marker already. And then in 2000, this is the first time that genetic criteria were introduced, but they were not used for diagnosing the tumors. And then in 2007, there was the fourth edition, and there, for the first time, it was much more developed, and you see some example in a moment, but it was not incorporated in the classification. That's a very important point. They were mentioning this tumor can have this feature or that feature, but it was not required for the classification. And so I want to take a moment to tell you what was the basis for the classical neuropathology grading. So there were 4 grades, 1, 2, 3, and 4. And the criteria that were used are known as the AMAN criteria: atypia, mitotic figures, vascular hyperplasia, endothelial proliferation, and necrosis, sometime with pseudopalisading. And by the way, some of these images were provided to me by our current fellow, Dr. Wang and Dr. Belacqua. And the other important point about the classical dogma was that a grade 1 can become a grade 2, a grade 2 can become a grade 3, and a grade 3 can become a grade 4. There was a logistic progression in the grading. So that was what was used in the early WHO classification. And there were already some work done on P53, on PDGFR, platelet-derived growth factor receptor, on CDK6 and CDK4, on the retinoblastoma, and on 10q loss and PTEN mutation. And there was an attempt of creating some kind of prognosis and some kind of grading that a grade 2 could become a grade 3 with additional molecular testing and eventually become a grade 4. And notice, by the way, on purpose, that the numbers here are Roman numeral, okay? 2, 3, and 4. And you can see here necrosis, pseudopalisading, prognosis, survival is 1 year, 2 or 3 years, and 5 to 10 years, okay? The problem became clear in the late 80s, where many papers came out and say, do we have issues with these criteria, the grading criteria and the progression concept? And specifically, there were tumors that had those 4 features, the AMAN criteria: necrosis and vascular proliferation and mitotic figure and atypia, and yet patients were not doing as bad as they were supposed to. And also there were some tumors, for example, what we call the pilocytic astrocytoma, that remains grade 1 for the life of the patient. So a grade 1 does not necessarily become a grade 2. And there were some grade 3 looking tumors that never became glioblastoma. So people started to say, well, maybe something needs to be done here. The other thing that was important was that international consortium. This was put together by Dr. Van den Bent in the Netherlands. There were some Italian, some French, some US contribution here. And they looked at the inter-observer variability. And this was a really important paper, because if you look at what it says in the paper, it says, for example, the panel reached consensus on the diagnosis of anaplastic oligodendroglioma. We're going to talk about this in a moment. In 52%. Can you imagine that in half of the cases, the diagnosis was not confirmed? Even worse, there were only 8% of local diagnosis of anaplastic oligodendroglioma confirmed by the consensus of experts. So clearly, there were issues here that were impeding clinical trial interpretation. And clinicians like Dr. Van den Bent from the Netherlands started to write a lot of paper in a way saying, well, maybe the neuropathological evaluation of brain tumor needs to be changed, because clearly it's difficult for us to design clinical trial and including patients in those trials based on what we currently have. And so there was a revised 4th edition. This was not the 5th edition. The previous one was the 4th edition. This was the revised in 2016. And for the first time, there were molecular diagnoses that were included, and they were indicated as required. And we'll talk about this diffuse midline glioma in a moment, H3K27, where there is a mutation of this tumor, and it's a grade 4. In addition to this, in between the 2016 and the 2021, there are a lot of additional supplements that we call the C-Impact Now, stand for Consortium to Inform Molecular and Practical Approaches to CNS Tumor Taxonomy. And this is when people get together before the new edition came up, and when they feel something is really critically important and cannot wait the next WHO edition. And so between the 2016 and the 2021, there were 7 of those. And all of this had critical implication, refining in a way the previous revised 4th edition. I'm going to be talking about the C-Impact Now throughout this talk, but it was clearly additional defining findings that helped tremendously prepare for the 2021 edition, which is the last edition we have. So this is an image that basically summarizes the 6 WHO, and you can see on the desk of our fellow, this is the 2016, and this is the 2021. You can see how much this has changed. And the reason this has changed is only because of one thing, and that is the inclusion of the molecular data. Okay? So this really illustrates very nicely that molecular evaluation of brain tumor is not only essential, it is required to basically practice neuropathology. So basically, the goal is to switch from a practice where you have all the patient together. So in black here is no clinical response, and in red is clinical response. And before you include molecular pathology, everybody gets the same treatment, radiotherapy, chemotherapy. And some of these patients do respond, but others do not respond. So the goal is to really, based on genomic pathology, define mutation A, B, and C, and of course, increase the number of responders. That is the goal. And using these biomarkers in neuro-oncology, you can help diagnosing the tumor, but also establishing the prognosis and predict the outcome of the patient. So one of the first important marker that was used is called the MGMT. So the MGMT is one that predicts whether or not a drug known as temozolomide, TMZ for short, with an alkylating agent, will or will not have an effect. So let me tell you how it works. The gene for this MGMT is either non-hypermethylated or hypermethylated. And when this promoter is hypermethylated, the gene is silenced. MGMT is not present. And when you give this drug to patient, temozolomide, this drug adds methyl group to the DNA of tumor cell. But the enzyme comes in and removes the methylation from the DNA of the tumor cell. And therefore, the tumor cells, rescue. If MGMT is not around, the methylating of the DNA of the tumor cell led to cell death. So it's basically a situation where you do not want MGMT present in your patient. And when we deal with a patient, the most important question the neuro-oncology will ask is MGMT methylated? Is the enzyme not present? And so this was a classic paper, it wasn't a pioneer paper by Dr. Stoop group that showed that was already having a major, major impact on whether or not the methylation was or was not present. So in the unmethylated patient, the outcome was worse. But I have to say, in my opinion, that the most important, I repeat, the most important contribution to neuro-oncology is the discovery of the IDH1 or IDH2 mutation. So IDH1 and IDH2 transform alpha-ketoglutarate into a compound 2-HD. When the mutant form are not there, the non-mutated form of IDH1 and IDH2 transform isocitrate here in the mitochondria or in the cytoplasm into alpha-ketoglutarate. And I have to take a moment to tell you about alpha-ketoglutarate. My lab is extremely interested in hypoxia-related molecular event. And alpha-ketoglutarate here is essential for the biological role of an enzyme called prolyl hydroxylase, Ph.D. And when Ph.D. is occurring in the presence of normoxia, oxygen is normal, and alpha-ketoglutarate is present, this prolyl hydroxylase hydroxylate IF1 alpha, which is the important subunit in the transcription factor IF1, and this leads to von Hippel-Lindau to ubiquitinate IF1 alpha that is then destroyed by the proteasome. And as you all know, people without von Hippel-Lindau develop tumors in their kidney, in their testicle, in the brain, hemangioblastomas, in the middle ear and the lymphatic sac tumors. All of these tumors occur because von Hippel-Lindau is not present, and therefore, even if one is hydroxylated by prolyl hydroxylase, it's not degraded. So this is the concept of what is known as von Hippel-Lindau syndrome. You all heard about VHL, of course. But this alpha-ketoglutarate, when the IDH is mutated, is then metabolized into 2-hydroxyglutarate. So you can see a glutarate. So clearly, you can see here how important is the presence of this mutation. And when you look at the type of mutation, this is a work done by the laboratory of Dr. Wein Daimling in Heidelberg, Germany. In 92% of cases, it's an arginine that is replaced by an histidine in localization 132. So the mutation is called IDH1 R132H. There are other mutations which are much, much less common, and sometimes it's not IDH1, but IDH2. And the antibody that we are using, this is essential to understand this, only recognize IDH R132H. So sometimes we have to do molecular testing because we strongly suspect that the IDH is mutated and the immunostain is negative, and therefore we want to rule out other mutation of IDH1 or an IDH2 mutation. And the reason I said that, in my opinion, this was the most important contribution done is because the impact on the survival is absolutely unbelievable. The IDH mutated tumor have a really significantly, statistically significantly much better outcome. Even if the slide shows necrosis, even if the slide shows mitotic figures, even if the slides show vascular proliferation. And now you understand what I talked about earlier, why patients had different outcome, even though they were diagnosed, for example, with a grade 4 glioblastoma. This was confirmed in other paper that was published in the New England Journal of Medicine. The previous paper was published in Cell, and you can see that in glioblastoma, again, the IDH mutated tumor have a much better prognosis. Whether it was called glioblastoma or anaplastic astrocytoma, grade 4, grade 3, you can see the outcome is much better. And thanks to Dr. Andreas van Dijmeling, we worked very hard and know Dr. van Dijmeling well. Dr. van Dijmeling told me that he had to really search and screen many antibodies to find the antibody that we are now using on every single tumor that we have, and that's a specific R132H antibody. And this is an extremely reliable staining, you can see here that the endothelial cells are negative and the tumor cells are positive. The inflammatory cells in the background are also negative. And I can tell you that I remember during my fellowship that my mentors was a superb neuropathologist, Gleb Badzilovich, who tell me sometime that he has difficulty being sure that a mildly hypercellular piece of brain was neoplastic. If we had the IDH1 immunostain, that would have solved the problem. Because if a cell has cytoplasmic staining, you know for sure that it is a tumor cell. So you no longer have the difficulty between infiltrating glioma or what we call gliosis, which is a reactive process. I hope this is clear for everybody, because really this was a major breakthrough in how we perform our analysis. And so what I'm going to be telling you is that the current classification of IDH mutated diffuse glioma, these are diffuse infiltrating glioma, has two kinds. The oligodendroglioma here, which has 1p19q co-deletion, in other words, loss of the short arm 1p and loss of the long arm of 19, and also have TERT mutation. In contrast, tumors have IDH mutation, p53 mutation in a significant number, not all, but a significant number, and ATRX mutation. I'm going to illustrate all this for you in a moment, are not oligodendroglioma, but are astrocytomas, grade 2, grade 4, and oligodendrogliomas grade 2 or grade 3. So this is an oligodendroglioma. The peak incidence is in patients from 30 to 60 years old. They are very often in the cerebral hemisphere. They usually present as seizures, and they are very often showing microcalcification, which is a very good clue to help recognize the tumor even before you have the pathology. And this is a microscopic slide of an oligodendroglioma. And you can see here that what we know is very classic, which is this round nuclei with perinuclear halo is not present. So it could be difficult to recognize this in some patients. And in addition to this, you have this branching very thin vasculature. Those are the two classical findings in oligodendroglioma. Also very important is the fact that these tumors are infiltrating gliomas. And you can see here on the right image that the tumor cell organized around neuron. Here the arrow points to a neuron here and here, but also around blood vessel. This is what we call perivascular satellitis, and this is perineuronal satellitis. These were described by Dr. Scherer, and Dr. Scherer was a German neuropathologist that did most of his work in Belgium. And this is what we call the secondary structures of Scherer. In this oligodendroglioma, you need to show IDH mutation. You can see the tumor cells are positive, but in addition, they have immunoreactivity for ATRX. I'll show you in a moment that if ATRX is lost, it's not an oligodendroglioma, but it is an astrocytoma. But the most important and required WHO feature is what we call 1p90q loss. So this is FISH, and in this case, I'm illustrating the 1p, but the same thing would be seen with the 1q. You can see in a non-neoplastic cells, you have 2 copies of each, and here you only have 1 copy of 1p because the second copy is lost. The WHO says very clearly that if you do not demonstrate 1p19q, you cannot make a definitive diagnosis of oligodendroglioma. That is essential required. So the WHO says that the diagnosis of oligodendroglioma requires demonstration of IDH mutation and 1p codeletion. You cannot avoid this. The other important diagnosis that was existing in the previous WHO is something called oligoastrocytoma. And Andreas wrote a very nice paper called Farewell to Oligoastrocytoma. And basically, there is no such a thing. That tumor have both ATRX loss, which is an astrocytoma, and 1p90q codeletion. They both IDH mutated. We agree on that. But they cannot have both. In my last 15 years experience, I've seen one case where we could demonstrate again and again, double checking everything, that the tumor was an oligoastrocytoma. Dr. Jason Hughes, who is the chief of neuropathology at MD Anderson, actually reported one paper that was published, one case that was published in Acta Neuropathologica. But this is an extremely rare occurrence. Tumors are usually either, in a vast majority of cases, oligoastrocytoma when they have IDH mutation and 1p90q codeletion, or astrocytoma when they have IDH mutation, ATRX loss, that I'm going to show you now. So this is an astrocytoma. Usually patient IDH mutated diffuse astrocytoma are less than 55 years of age. They have this poorly defined abnormality that in this case does not show contrast enhancement. In some cases, you have contrast enhancement, and usually it goes along a more aggressive tumor. The tumor show this sort of irregular nuclei. Sometimes they have what we call a gemistocytic appearance. The tumor is IDH mutated. It is required, and also has ATRX loss. The antibody recognize the normal ATRX. And you can see here with this green arrow that the endothelial cells, which are normal, non-neoplastic endothelial cells, have ATRX expression, but the tumor cells have lost expression of ATRX. And sometimes, as I said, this astrocytoma also show p53 immunoreactivity. And when you have so many cells, it's easy to predict that p53 is mutated. So ATRX mutation or loss leads to activation of something called alternative lengthening of telomere, or ALT for short. And that basically bypasses the normal occurring shortening of the telomere that's happening in normal cells. And this leads to uncontrolled growth and uncontrolled maintenance of the cell, which is why an important aspect of these astrocytomas. These astrocytomas are grade 2 to grade 4. They're never grade 1. And in the grade 3, you have some anaplasia, some mitotic figure, but microvascular proliferation, necrosis, or homozygous deletion of CDKN2A are absent. In contrast, if any of these 3 findings are present, it's automatically a grade 4. So if you have an IDH mutated tumor, it is ATRX loss, and you have microvascular proliferation, it's a grade 4. You have necrosis by itself, it's a grade 4. Homozygous deletion, again, this is why it's so important to do the molecular testing. Now, I want to tell you that sometimes we have patients that we see on consultation, and they have been giving a diagnosis of GBM. And we had a patient not too long ago that was diagnosed 11 years ago, who was given a diagnosis of glioblastoma. Well, it was not a glioblastoma, and that's why the patient is still alive. It's an IDH mutated tumor that in that case, this is the case I'm showing you now, had IDH mutation and ATRX loss. So clearly, these molecular tests are essential because you can tell the patient if they do or do not have a glioblastoma, okay? As a matter of fact, the WHO says that if you have a tumor that has all the features, necrosis, mitotic figures, vascular hyperplasia, and that's IDH mutated, you cannot call this tumor glioblastoma, okay? It's very simple, but extremely important. As important is this, and this is really what I want to stress again and again, is that we have now IDH inhibitor. So that this great work has translated in how you care for your patient. And this is a patient, courtesy of Dr. Alexandra Miller, who is Chief of Neuro-Oncology at NYU. This is a patient, is 46-year-old woman. And this woman had a grade 2 oligodendroglioma diagnosed back in 2021. And she was given this drug named Voranigo. This is an FDA-approved medication, and you can, if you think this is the diagnosis, of course, give it to astrocytoma or oligodendroglioma, but the patient had to have surgery, and the patient had to have a grade 2, not a grade 3. And look at the effect of the drug. The drug was starting in December, and this is about 6 months later. This is the surgical cavity, and you can see the pericavitarial abnormality, and look what happened now. Just a couple of months ago, this tumor has not progressed. I mean, this is what is the effort about, to be translational. And that is, in my opinion, the most important, the most reason why it's so important to pursue this molecular workup. In contrast, and unfortunately, a tumor that's IDH wild type, that is diffusely infiltrating, that has microvascular proliferation or necrosis, or third promoter mutation, or EGFR and GN application, or 7 gain and 10 loss, is a glioblastoma WHO grade 4. So you don't need to have all of these. It's one or the other. There are 5 defining criteria to be able to call this very, very necrotic, very, very infiltrative. I think you appreciate here how this tumor has deformed and displays the midline, but is also infiltrating this area of the brain that we call the corpus callosum. In some cases, you do not have this necrosis with pseudopalisading. You do not have vascular hyperplasia. You may or may not have some nuclear atypia, and you very often have vascular thrombosis. But in some cases, you don't have these morphological features, but you find a TERT mutation in an IDH wild-type tumor. This is what we call a molecular GBM. I hope you're following me, that there are cases when on morphological ground, you know it's a glioblastoma, you do molecular testing, and you can confirm it. But there are cases where you cannot see these morphological changes, but on the molecular testing, you can make a diagnosis of a GBM. I hope it's clear to everybody. I want to say that this thrombose vessel is the work of Dr. Greg Orbinski, Northwestern. We published this paper in collaboration with him. When you have an IDH mutated tumor, you do not see these thrombosed vessels. And so when you look around at the glioblastoma and you will likely see thrombosis. And actually, if you see thrombosis, you have a very strong suspicion that you're dealing with a glioblastoma. So just to wrap this part of the talk, you start with a diffuse glioma, IDH mutation with 1p90q co-deletion. Third mutation is an oligodendroglioma. With p53 mutation, ATRX mutation loss, it's an astrocytoma. If it's IDH wild type, EGFR mutation, third mutation, it's a glioblastoma. I think this is the state of the art in 2025, and without performing molecular testing, you cannot do it. So the WHO has made significant changes. First of all, you're not using the Roman numeral. You have to using the Arabic numeral because, first of all, it conforms to other grading system elsewhere in the body, but also sometimes there were typographical error. You can understand that sometimes instead of 2, there were 3, or instead of 3. Clearly, Arabic numeral is less likely to be mistakenly written. The most important, as I stressed again, high-grade IDH mutated tumor are not GBM, okay? Grading within tumor type, the use of terminology such anaplasia, anaplastic is not recommended. You just say astrocytoma, comma, IDH mutated, comma, and you give the grade. No anaplastic, but because there's too much variability in between pathologists. So clearly you have to follow the rule of grading and subtype. You do not use this within the grading. The other important way is doing what's called the integrated layer diagnosis. And this is an example, glioblastoma, IDH wild type, CNS, WHO grade 4, because you have been able to confirm this on the molecular testing, okay? I want to move on for 1 second and give credit to our colleague in neuroradiology that have basically shown a great deal of interest in understanding of this classification. And they can fairly often predict whether a tumor is an astrocytoma or an oligodendroglioma. And in these sequences, it's very simple. In T2, the CSF, you see these are the ventricle is white. In a T2 sequence, the tumor is bright. And what's known as the flare sequence, the tumor is dark. And you have sometimes partial decrease in signal, but this is called the T2 flare mismatch, is very much predicting that you're going to be dealing with an IDH mutated 1p19q, not co-deleted, meaning an astrocytoma and not an oligodendroglioma. This is not what an oligodendroglioma would do. So you can see that in addition to neuropathology changes, this has an impact also on how a neuroradiologist practice their readout. So I'm going to switch now to the BRAF mutation. And again, I'm emphasizing this because we have BRAF inhibitor. You now understand the way this lecture is organized. And normally BRAF is an important part of what we call the signaling pathway. And normally ERK and MEK lead to a normal cellular proliferation and survival. But when BRAF is mutated, and this is called V600E because a valine is replaced by glutamic acid. This is a gene that's located on chromosome 7, specifically on 7p34 region. When this mutation occurs, the proliferation is uncontrolled. and also the survival is increased. So this is compatible with the neoplastic state. And there are two tumors that we know have this mutation. The first one is a ganglioglioma. And sometimes you have gangliogliomas which cannot be completely resected because they could be in an area of the brain that's difficult to resect. And therefore, these inhibitors are essential complement to the surgery. The tissue shows these large ganglion cells. Very often there is a perivascular infiltration. There is also GFAP immunoreactivity in the astrocytic component of this ganglioglioma. The synaptophysin is also highlighted. It's what we call pericardial staining. But most importantly, there is a BRAF V600E immunoreactivity. Andreas van Dijmeling told me that he believed this antibody is not as reliable. Andreas van Dijmeling is an amazing scientist, an extremely honest scientist, told me that the antibody for BRAF is not as good as the IDH R132 antibody. So what this tells you is if you strongly suspect the BRAF V600 mutation and the antibody is not giving you a definitive answer, you are better doing the molecular evaluation. And we had cases like this because, again, from the person that made the antibody reliability is not 100%. And you can see this tumor here in the posterior fossa of this individual showing a classic. The other kind of tumor that is BRAF 600E mutated is a tumor known as a pleomorphic xanthoastrocytoma. And I'm showing this again because you can strongly suspect the diagnosis when you have a large cystic neoplasm with what we call a superficial nodule here. And you can see that sometimes there is septation in this mural nodule. But what is remarkable is the fact that there is a significant degree of pleomorphism. There is also some xanthomatous changes, but most importantly, again, you can demonstrate BRAF V600E immunoreactivity. And in both of these cases, you can do molecular testing. And I'll show you in a moment methylation array for one of these PXA that is showing this definitively. Okay, so now we get to a very, very aggressive tumor. This child that I told you was the GLIHO Foundation had an H3K27 mutation. We actually reviewed her slide and we agreed with the diagnosis that was rendered in Europe. And what it is basically, you know that histones has this octamer. There are actually 8 subunits, and they're basically, the DNA wraps around the histone, and this histone regulate DNA, provide DNA structure, but also regulate gene expression. And in the H3 subunit, next to the H4, the H2B, and the H2A, on the chain coming up of this histone in position K27, a mutation can occur where a lysine is replaced by a methionine. And this is why it's called K27. So H3 is the H3 subunit. K is lysine, M is methionine, and 27 is where the mutation occurs. These tumors are high-grade tumor. And unfortunately, as of today, I can tell you that if you make a diagnosis of an H3K27 mutant diffuse midline glioma, the prognosis of the patient is not good. There have been some attempts. There is a medication called ONC201, but to be honest, I don't sincerely and honestly feel that this has the same impact of the inhibitor for IDH1 or the inhibitor for BRAF. It's an effort that's ongoing, and I cannot be telling you today that this is the treatment for this disease. This tumor can occur in the midline. You can see here an example, They often are located in the thalamus. They can also be in the pons. You can see here is the midbrain, the pons, and the medulla, right here in the pons, and they can also be in the spinal cord. In some cases, you have no problem recognizing a tumor. It's highly cellular, and you have no problem. In other cases, the cellularity can be less, maybe because the sample is at the edge of the tumor. But in those cases, like you had for the IDH mutated, the K27 antibody is a superb antibody, and that is 100% reliable. You can see that if you have a K27M positive tumor, you know for sure that it is what it is. So this is another example where in combination with genetic testing, the immunoreactivity is essential and extremely helpful. And in the vast majority of cases, the immunohistochemistry is confirmed by molecular testing. Now, I would like to talk about methylation. This is the work of Dr. Pfister in Heidelberger and a lot of my good friend, Dr. Van Dijmeling, Dr. Pfister, all of this tremendous effort, which have done a major thing helping neuro-oncology practice. So methylation array is basically using, is a fingerprint, a memory, if you like, of the origin of the cell. And this is really affecting the expression pattern of the degree of methylation. And this helps you to know in a very significant, reliable way, what is the cell of origin. And I'm going to show you an example where it's really, without any doubt, tremendously helpful, sometimes so much more helpful than the morphology. And so basically, there is a reference cohort. The machine is called the 450K Illumina, and you have the patient sample that is matched to the cohort, and you can get basically a definitive diagnosis about what kind of tumor it is. Can you imagine? This is so helpful in so many cases where you don't know for sure. For example, if you have a small cell glioblastoma or a primitive tumor, because the cells are very small, very highly packed, which one of this, and this cell solve the problem tremendously, reliably every single time. In addition to this, it gives you a copy number. So basically what you have here is chromosome 1, chromosome 2, chromosome 3, all the way here to chromosome X and Y, and there is amplification or loss. And for example, in the 1p19q, if you had the copy number for an oligodendroglioma, you would have loss of 1p and loss of 19q. Okay, so we still do 1p19q at NYU with loss of heterozygosity, but we are working on the validation of the copy number profile in methylation that will prevent the need to do it by FISH that I showed you and illustrated before, or what we are using at NYU, which is called loss of heterozygosity, using 7 probes on chromosome 1 and 5 on chromosome 19. The other thing that's remarkable is called a t-SNE. It basically tells you the case that you are studying is basically clustering with what other. And in many cases, you can see your case in the middle of a cluster. Sometimes it's adjacent, but this t-SNE here was done in 28,000 samples. This was back in 2019. Now we are about at 15,000 samples. So you can see that there is a refining of this clustering that is tremendously helpful. So here is an example how methylation was so helpful. This is a case that we got, consult, 17-year-old patient presented with a seizure. The MRI shows the enhancing lesion here in the left parasagittal region. And you can see that in this case, the only subtotal resection was done. The slides were sent to 2 separate experts. One thought it was a glioblastoma WH4. and the other one thought was a primitive neuroectodermal tumor, WHO grade 4. The first recommendation would be tumor radiotherapy and tumor radiation and chemotherapy. The second one would be craniospinal irradiation and PNET chemotherapy. The cells were mildly packed. There were some area here that looked more primitive, and partly why one of the experts thought it was a primitive neuroectodermal tumor. The tumor had diffuse GFAP, but also synaptophysin positivity, clearly explaining the difficulty in the diagnosis. When methylation was done, it turned out to be a pleomorphic xanthoastrocytoma that was confirmed at NYU performing an immunostain for BRAF V600E, basically consistent with the methylation diagnosis of BRAF 600E. The recommended therapy was not radiotherapy, was not chemotherapy, was gross total resection first. And in case of subtotal resection, the need of targeted therapy because of the numerous BRAF inhibitor that you have available now would be recommended. So clearly, you can see the impact of methylation. The other very, very important, I mean, I cannot stress again, the impact of methylation, and that is in medulloblastoma. As you know, these are tumors that occur primarily in kids, and this is a tumor that sits right there in the middle of the posterior fossa. This was a classical case, and this is the autopsy finding. The tumor had a very classic medulloblastoma, immature looking appearance. But when you actually look at the old classification, there are 4 subtypes. One called classic, one called desmoplastic nodular, one called extensive nodularity, and one called large cells anaplastic. And when you look at the paper there, at that time, using the morphological, desmoplastic nodular did okay, classic did in the middle, and the large cell anaplastic did worse. When molecular testing and methylation were performed, turns out that the classic type can have a Wnt pathway, which is a good subtype, but a large cell anaplastic cap can also have a Wnt pathway. So clearly, the morphology is not enough. And you can see that doing a molecular testing, a molecular evaluation, there are actually 4 types of medulloblastoma. And the sonic hedgehog here again, you can have a sonic hedgehog medulloblastoma that has a desmoplastic nodular type, or classic, or an LCA. So how can you predict the outcome of the patient when you know that Wnt pathway are, look at this, look at the outcome, look at the survival of this kid. Isn't that amazing? A Wnt pathway medulloblastoma is sometimes treated just with focal radiotherapy, not craniospinal irradiation, just to the bed, no chemotherapy. In contrast, group C, which is the worst one, which have the MYC amplification, or group D have a much worse outcome. The sonic hedgehog, I will tell you in a moment, has a better prognosis, but I'll tell you in a moment that within the sonic hedgehog, there are actually 2 groups, depending on whether or not p53 mutation is also seen. So basically, here are 2 kids. One is 4 years old, the other one is 5 years old. They have immuno and they have H&E appearance, synaptophysin, all that's very, very similar. It's difficult to know whether or not this kid is going to do, well or not. And there are immunostains that you can try. One of the good and reliable one that we have at NYU is called beta-catenin. And in the Wnt pathway subtype, the first subtype I showed you, there is nuclear immunoreactivity for beta-catenin. There are other markers, but some people like to use them, and others say that they are not very reliable. But what's important in the immunostain that you can predict very often is a p53 mutation in a sonic hedgehog is usually a more aggressive type of medulloblastoma. Whereas if p53 is negative, if p53 is not mutated, the prognosis of that child with the sonic hedgehog medulloblastoma would be better. And also, it is recommended in all of these patients to do an ENI1 immunostain to rule out what's called an atypical rhabdoid tumor. So in all of this medulloblastoma, this immunohistochemistry should retain INI1 staining. And so here is a case of a tumor that clearly has a primitive medulloblastoma appearance. There were mitotic figures, there was some molding, some multinucleation. INI1 was preserved, indicating it's not an atypical rhabdoid tumor. Beta-catenin did not show nuclear staining, was membranous, was cytoplasmic, so you knew it was not a Wnt pathway. p53 was negative. So if this would turn out to be a sonic hedgehog, this child would have a good prognosis because, again, sonic hedgehog medulloblastoma without p53 do much better than those that have p53 mutation. So methylation was done, and fortunately for the child, you can see that it matched with the sonic hedgehog, and in the absence of p53 mutation, this child has a completely flat copy number, which is very, very compatible with the lack of p53 mutation. So in summary, medulloblastoma is another example of how this morphological evaluation, which is of interest, if it's important, is not reliable. Because as I showed you, Wnt pathway can have one or more appearance. Sonic hedgehog pathway could have more than one appearance. So clearly you cannot use the morphology of the medulloblastoma to predict the subtype of this tumor. I hope I've made myself clear in basically demonstrating to you that methylation that we have at NYU is essential. Now, I'm going to conclude. I obviously could not do everything in this book, but I want to conclude by saying that this work is still ongoing. This is a paper that we took part of back in 2015, already 10 years ago. But this paper that was authored by Dr. Pashler, we had with Dr. Karajanis and Dr. Allen at NYU contributed to the understanding by providing them tissue from our frozen bank, but also from evaluation of the morphology. And that paper demonstrates without doubt that methylation profiling that classify this that's ependymoma into 9 subtypes, whether they are in the posterior foci or in the supratentorial region or in the spinal cord, and that this molecular classification really outperformed significantly the histopathological grading of this of these tumors. This is a paper that is published in Cancer Cell. So I'd like to conclude by saying that I hope I was able to illustrate that molecular studies have shown distinct subgroup of tumor. They have tremendously helped refine the diagnosis and classification, and most importantly, the management of the patient, and help certainly design tailored therapy. And this integrated approach in 2021 is still ongoing now. We have new C-impact now that are coming, and the next revised edition will be hopefully even more helpful to a patient. But the most important point that I made earlier and that I like to emphasize one more time, clinical trial should not be evaluated without it, because you're going to get result. How can you analyze an IDH mutated tumor that has necrosis, microvascular proliferation, mitotic figure with an IDH wild-type glioblastoma? They are not tumor. The prognosis of the tumor to begin with is better when the IDH is mutated. So how are you going to be able to assess the effect of a chemotherapeutic drug if the patient outcome is to begin with better. So basically, linking all these four circles, all these features is really, really what is essential. I want to end by thanking the members of my lab, members of the Department of Pathology, the Genomic Core, in the Division of Neuropathology, Dr. Faustin, Dr. William, Dr. Snoodle, all our fellows, our current fellow, Dr. Belacqua and Dr. Wang, were helpful in giving some of these pictures, but also the previous fellow, Dr. Movaed Izazi, who is now attending in New Jersey, Dr. Caitlin, who is now attending in Seattle, Dr. Leah, who is now in the medical examiner next door. So all of these people that really have been tremendously helpful, all the neurosurgeons that have given us all this tissue to be able to do these studies, all the members of Neuro-Oncology, Alexandra Miller, that gave us some of the information you saw today, members of the Neuroradiology, you can see how they applied this molecular data, and Dr. Shiriboka, that's so important. But also want to acknowledge the help and the collaboration with our colleague in Germany with the methylation work and the molecular work. So I believe I'm done, and I thank you very, very much for your attention.
Thank you so much, Dr. Zagzag. It's a really great talk. And our audience today, the peak is 170. So we have a lots of audience. You can see lots of thumbs up, and it's a really comprehensive, great talk, and especially how molecular reshape this entities. So right now is our QA time, and you can find the question in our QA box.
Okay, so I have a question here. I have 4 questions, I believe. So great talk, thanks. Can gliosis have TERT and p53 mutation? So that's a superb question. I can tell you that you can be misleaded, listen to me carefully, with, for example, a p53 immunostain. I have seen cases of demyelinating disease. Demyelinating disease, you know what it is, like multiple sclerosis, aggressive nature, that have p53 staining. So you have to be careful. So I did not touch on the non-neoplastic diseases mimicking tumors. We published a lot of papers on that, not just demyelinating disease, but a lot of infectious disease, a lot of other pathological process that are not neoplastic. We have a paper published in the Archive of Pathology and Laboratory Medicine where we describe about 15 cases. And I have personally published a lot of papers on demyelinating disease mimicking neoplasia. So you have a very, very important role here in understanding that clearly this is very important. The second question is, why is DNA manipulation particularly helpful for tumor classification neuropathology, but not well adopted in other pathology subspecialty? Well, I'm not sure I have the answer to that one. It's a great question. My prediction is, molecular pathology started with hematopathology, right? So neuropathology started after, but I think, caught hematopathology. It is my prediction. Whether it's going to take 10 years or 15 years, but we are now in 2025. My prediction is that molecular and methylation will be translated in other subspecialties in pathology. And I can tell you that probably one of the reasons is the main engine behind it, Dr. Pfister, is a neuro-oncologist. So maybe because he was primarily interested in brain tumor, maybe that's why. But I have no doubt, mark my word, for the record, that this will be expanded. The other one is the case with diagnosis of GBM PNE tumor. Does the pathologist update the diagnosis with methylation finding? If so, do you back to all the tumor miss? Absolutely. Absolutely. We have absolutely no doubt. And, I'll tell you, one patient called and say, you called me my tumor a glioblastoma 11, 12 years ago, and you know what? I'm still alive. Well, of course, we said that's great news. But upon methylation, it turns out that it was a mistakenly glioblastoma. It was an IDH mutated tumor. So all of what I've told you today has daily implication on our practice, daily implication on our patients. So yes, absolutely. Question now is, does glioma have genomic instability such as chromosome deletion amplification? Okay. I'll tell you, my lab is very interested in hypoxia. And these tumors, these gliomas, such as GBM, when they're hypoxic, they have a great degree, a great level of genomic instability. So, and the answer to your question is absolutely. The last question I see here is, what is the case volume of medioblastoma at NYU anyway? Does NYU perform long-range sequencing such as nanopalm sequencing? So the number of medulloblastoma at NYU has decreased lately. We had one of our very famous neurosurgeon, Dr. Jeffrey Wissoff, who retired. We are hiring 2 pediatric neurosurgeons. One is our own trainee that's currently doing a pediatric neurosurgery training at MD Anderson with Dr. Howard Weiner. And another pediatric neurosurgeon is coming from California. So we will soon have 5 pediatric neurosurgeons, and I believe that the number of cases will go back, but it currently certainly went a little bit down. Last question here is, are you going to have lawsuit because of that? Because of what? Oh, because of what I said? You know, I guess medical legal implications are real. I think that the standard of care at the time of the diagnosis, where it was, so as long as you make the inaccuracy at the wrong time, that's right time is good. But if you now call it GBM, an IDH mutated tumor, I'm afraid you may have a medical legal consequences. Absolutely. This question is, great talk. Thanks. There are no out criteria distinction between grade 2 and grade 3 of IDH metastasia. How do you grade this tumor? The morphologically for astrocytoma, I don't know if I can go back to my Kodachrome, but if a tumor is an IDH mutated astrocytoma and has microvascular proliferation or necrosis or CDKN2 homozygous deletion, it's automatically a grade 4. So necrosis and vascular proliferation are reliable. It's less definitive in oligodendroglioma, which had the 1p19q and IDH mutation. But in astrocytoma, the morphological appearance is more reliable than in oligodendroglioma. What is your suggestion on frozen section? So, listen, I would tell you that this question is a question that I discuss with my fellow every single time. The goal of a frozen section should be well defined with the surgeon. This is an extremely important question. What is the goal of the frozen section? If the surgeon asks you to grade a glioma, you will have to be extremely careful. First of all, if you're sure it's a tumor, then if you have obvious necrosis and pseudopalissading, if you have obvious microvascular proliferation, then you can suggest to the surgeon that is probably a high-grade tumor. But if you don't have those, even after permanent section came out, you have some tumors where the grading can be difficult on morphological ground alone. So then even more so on frozen section. So my advice And my teaching to my fellow is be very careful on frozen section. And my mentors have told me, my two main mentors, Dr. Budzilovich and Dr. Feigen, is that a surgeon, listen to this very carefully, can always go back to the operating room. But if the surgeon removes a temporal lobe and you're wrong and it's not a tumor, there is no way that surgeon is going to be able to put back the temporal lobe. So a frozen section is an important part of our job, and my recommendation to all of us is to be extremely, extremely careful. I think that was the last question.
Okay, I think that's all the questions. Thank you, Dr. Zagzag. Thank you so much again, and
Thank you. Thank you
yeah,
very much.
all the audience, and have a good weekend. Thank
Thank
you.
you so much. Thank you, everybody. Have a wonderful, wonderful weekend. Bye.
You too. Thank you.
Bye-bye.
Bye bye.